We have about 40 minutes for our panel. And before we launch into questions from the audience, we've asked our two panel discussants, Michael Kelley and Lucas Amler, to take about 5 minutes each. And what we're hoping they will discuss in their opening remarks relates to the challenges that we've seen outlined by our speakers already this morning regarding the evidence needed to demonstrate the clinical utility of some of these computational approaches that we've seen presented, good examples by Holt Oliver, as well as the decision support systems that have been implemented for precision medicine, as well as what some of the policy issues might be needed as we start to think about, some of Lee Newcomer's comments, which I think helped frame that policy discussion very nicely. But if we could give Michael Kelley, if you'd like to start first in your comments, you've got about 5 minutes.
Thank you. Okay, there we go. So thank you for inviting me. So VA is the nation's largest integrated healthcare system. There are about 9 million enrolled veterans, which is about 40% of all veterans in the United States. And it covers a broad geographic area. So our cancer population is very similar to American men. As you see on the left, there are about 50,000 new cancers diagnosed in VA every year, which is about 3% of the country, or about the 10th largest state. We do have a higher than average population of African Americans and a very high percentage of rural veterans. It's more than twice as much as the national average. So we have a very broadly distributed population to serve. In the Cancer Moonshot in 2016, we started our national precision oncology program, which is essentially focused on solid tumors by doing multi-gene panel NGS testing. You see that was implemented in about July of 2016. And since then, we've rapidly expanded across the system. We're into over half of the centers which are treating cancer patients, and we're doing just under 1,000 samples every quarter. The results are very similar to what has been shown previously. The cancers in the columns are shown in the frequency which they've been tested. So lung cancer was our initial target, but prostate cancer is coming up very rapidly now. There are about 4,500 men with prostate cancer who are receiving a drug for metastatic prostate cancer, and with the advent of therapies both on label and in clinical trials for HRD mutant prostate cancers, we think that probably all of those are going to get tested. So this just shows the level of evidence that our genetic results have shown. So level 1 is on label, it's 8.3%. A little bit of level 2A, 2, which most people would also treat and be reimbursed. This is very similar to what Memorial Sloan Kettering reported, which was about 7% for level 1. The difference is that we don't have as many clinical trials, and so that's another active area that we're working with the NCI and other partners to increase our availability of off-label treatments through clinical trials. We did look at different ways of annotating the results of our NGS results. So we did receive a gift from IBM for the use of their annotation service. And we also looked at the commercial results that we got from our NGS vendors, as well as the publicly available OncoKB data set. And I think what you can see is that although this is called precision oncology, there is not precision in the interpretation of the results, even at the pathogenicity level. And at the actionability level, there's also not very good agreement between OncoKB and Watson for genomics. We have several services that we provide in addition to NGS testing. So we have an electronic consult service, which is on-demand, asynchronous, and patient-specific. So we have a unified electronic health record system. So anyone can ask us to provide an opinion for their patient, and we can do that in about 72 hours or less. and that's done with a multidisciplinary input that's focused through review of that individual patient's entire context of their treatment course. We also have an educational conference, which is case-based, that we call the Molecular Tumor Board. We have a database for research. There's several different proposals that are going on now with that database. And we also have a genomic medicine service, which is a telehealth provided genetic counseling if we find patients that have germline genetic alterations. So we're only doing somatic testing, but the prostate cancer is going to be the area where there's going to be a lot more patients who are discovered to have germline genetic alterations. And then just finally, just showing you some of the data flows. So we get the data back from the NGS vendors, both to the individual provider at their hospital and also centrally into a database. So we can compute on that and put that into a pile. We can re-annotate it, and we can put it into our corporate data warehouse, augment the NGS results with drug exposures, response, other data elements. And this is just some of the, on the right, you can see there's like a patient dashboard that displays back all the oncology relevant data, including the NGS testing. And so that's our interactions. So I guess that's an add-on in Mia's world. Thank you very much. So just wanted to give you an overview of where we are in VA.